Just to check, Dr. Chang, you have allowed participants to be admitted from the APSC cloud side. Participants can come in right now.
Yes, yes, they can come in.
So we'll start exactly on time at 11.
Yes.
And maybe I can request for everyone else to be muted when we start. Okay, so it's 11 a.m. So we'll start the session now so that to give everyone the appropriate timing. I think I will just introduce the session if you're okay, Prof. Lin. Then we can start. Thanks a lot. My name is Jack, the current president of the APSC. And I would like to again congratulate the APSC Cloud team for putting out this very exciting webinar, which I'm actually here to ask a lot of questions from my speakers. And I hope to learn from them as well. So despite the establishment of a lot of evidence-based hypertension trials and treatment guidelines like the SPRINT, JNC 7-8, we're still equally confused. There's too many numbers, there's too much trials, there's too many subgroups. And I think here today, we have tons of dilemmas in the management of hypertension, especially in subgroups and certain comorbidities. And this field remains confusing to a lot of general cardiologists, especially across Asia Pac. So we have two sessions focusing on hypertension today. Part one of the Hypertension Forum, which I'm chairing, will focus on hypertension management strategies during this period of COVID-19 pandemic, after which we'll move on to how to manage a subgroup with blood pressure variability. And the session two, which will be chaired by Professor Koji, will focus on women in pregnancy hypertension and for those subgroups with chronic kidney disease. So I would like to first introduce the first speaker, a good friend of mine from the Philippines, Jorge Sison, the consultant adult cardiologist from McCarthy Medical Center. And his talk to us today would be hypertension guideline during COVID-19 pandemic, the Asia Pacific point of view, after which we'll take a quick Q&A before the second speaker. The second speaker will be Prof. Takayu Kishi, Department of Graduate School Cardiology, International University of Health and Welfare, Fukuoka, Japan. He's going to talk to us on treatment strategies for hypertension with blood pressure variability, which is also a very difficult subset to manage. And we're going to hear his point of view as well. So without further ado, Sison, please take it away.
Thank you, Jack. And
yeah, thank you.
Thank you to the APSC Taiwan Society for inviting me to share with you a very important topic on hypertension guidelines in the COVID era. And I would like to share my slide. I hope everybody can see my slide now.
It's good. Please go ahead.
The title, yeah, thank you. The title of my talk is about hypertension guideline during the COVID pandemic point of view in the Asia Pacific. These are my disclosures. I start off with a case study that we see in our day-to-day practice. We have a case of a 63-year-old man, hypertensive since age 46. He's diabetic, smoker, sedentary, and then 5 days ago, he started to have cough, sore throat, myalgia, and slight shortness of breath. And he's been on regular telmisartan and aspirin. As you can see, blood pressure is okay, a little tachycardic, he's a little obese, and he has fever. When you do the examination, he has a RALS in the right lung field. So these are the laboratories that we requested. You can see there's a LVH with looks like an old MI. And then when we did chest x-ray, truly there was a sign of pneumonia with cardiomegaly. And we have confirmed that this patient had really COVID positive on the PCR test. So if I will look at the salient feature, we have a 62 male with hypertension, all the risk factors, smoking, and all the symptoms I presented, regular on telmisartan, aspirin, and he has RALS and signs of pneumonia, LVH, and he's positive for COVID PCR test. So our next move will be what to do. We're going to hospitalize? Are we going to start the COVID treatment protocol? Are we going to continue with aspirin? Are we going to change the telmisartan to a CCP because of the concern that we are raising nowadays? So here is my agenda for my lecture, background, and then some epidemiology, and then the RAS blockers concept, and then the guidelines across the Asian Pacific perspective. So first, the background. Just a reminder that the COVID-19 broke out first in Wuhan and then spread almost every country in the world. Millions were affected, many died, and every day our life has completely changed. And it has been shown that the SARS-CoV virus has been detected in multiple organs, so that we consider the SARS-CoV as a multi-organ tropic, or has a multi-organ tropism. No? The prognosis initially was good with mild disease, but however, some patients or many patients will show sudden deterioration or progression and became worse after the symptom onset, and then they end up with ARDS and significant manifestation of the disease. So it has been identified that the comorbidities that leads to a risk for a COVID-19 serious illness is age. You know, the older the age, the higher the risk. And then we see cardiovascular disease, diabetes, chronic lungs, and these are the prognostic factors for mortality in COVID. Now we go to the epidemiology. If you backtrack in March, where we saw increasing data in Italy, in March there were about 3,200 COVID deaths, and then they saw that the patients who died had an average age of 78.5 years, and then almost 99% of them had at least one comorbidity. And one of the common comorbidity was hypertension in that observation in Italy, affecting almost 72% of patients. And half of them, or more than half of them, were taking RAS blockers, ARBs or ACE inhibitors. So that began to raise questions about the role of the drug. Now, there's another study done in China showing that the comorbidity, most common comorbidity is hypertension, followed by cardiovascular disease and diabetes. So these are the top three comorbidities seen during those early months of the COVID pandemic. And what are the comorbidities that are related to high mortality? In this study in China, it's COPD, diabetes, hypertension, and malignant tumors. Likewise, the number of comorbidities also predict mortality. No? At least one comorbidity will give you already a risk for mortality, but gives you higher risk if you have two or more comorbidities. Now we go to the role of renin-angiotensin system and role of renin-angiosystem blockers. Well, we be reminded of the RAS system. We all are very familiar with this cascade from angiotensinogen converted to angiotensin 1 and then angiotensin 2 through the ACE function. And the angiotensin 2 will act on by stimulating the type 1 receptor to give you all the negative hemodynamic effects of angiotensin 2, okay? But we are now focusing on another aspect of this RAS cascade, which is the ACE2. As you can see here, we are reminded that the ACE2 converts angiotensin 1 to angiotensin 1,9. And this with angiotensin 1,9, again, it's cleaved by the angiotensin converting enzyme to become angiotensin 1,7, which we see as a good guy, because if we have angiotensin 1,7, it gives us the beneficial effects of vasorelaxation, cardioprotection, antioxidant effect, anti-inflammatory, and all of these beneficial effects. On the other hand, the ACE2 is also converting angiotensin 2 directly to become angiotensin 1,7. So remember, it is the angiotensin 1,7 that we like. It is beneficial for our hemodynamics. And we have also been informed and in the studies that the SARS-CoV or the virus binds itself, the spikes of the virus, the coronavirus binds itself with that enzyme, the ACE2, to facilitate its entry into the cell, no? More particularly in the respiratory tract. And if we have this coronavirus using the ACE2 to enter the cell, what happens is you downgrade the availability of the ACE2, which we like, because the ACE2 converts the bad angiotensin 2 to good angiotensin 1-7, and also angiotensin 1 to angiotensin 1,9. But because of the downgrading of the angiotensin converting enzyme 2, you prevent the conversion to the good ones, and therefore you leave high levels of angiotensin 2 to give its bad effect on the lungs, on the cardiovascular system, inflammation, etc. So in summary, we have the virus, the SARS-CoV-2, and of course we also remember the original one, the SARS-CoV. Both of them promotes the level of angiotensin 2, as I've explained to you, and at the same time, they downgrade the availability of the ACE2 and prevent the conversion to the good angiotensin 1,7, which we prefer. So again, putting it in another perspective, if you have this virus entering the cell membrane using the ACE2, therefore you deplete the cell membrane tissue ACE2 that is supposed to be the source of your plasma ACE2. So you deplete the plasma ACE2, which is important to cleave the angiotensin 1 to the protective angiotensin 1,7. So this is what's happening in the theoretical aspect of renin-angiotensin system and the coronavirus. And what happens if you have the coronavirus invading our cells? Then it creates a lot of injury to the heart, leading to myocarditis, leading to myocardial damage, the lungs, leading to ARDS, hypoxia, leading to um, respiratory failure, and also the vascular aspect and the coagulancy system are also affected, giving us thrombosis, hypercoagulability, endothelial dysfunction, and of course, coronary artery plaque rupture gives us cases of ACV. This is happening now in coronavirus infection or COVID-2. The fact that the SARS-CoV virus uses the our cells, the vulnerable cells, it means, therefore, that the ACE2, when it is expressed highly in one organ, it will be most susceptible, no? And that is the lungs. That is where it's most susceptible. And we thought that the ARB and the ACE inhibitors have been shown experimentally to increase or promote the levels of ACE2, as I have shown you in my previous slides. So therefore, we are concerned about the potential higher infection if we use these drugs, no? Because of its utilization of the ACE2 enzyme. But this was debunked by Reynolds in his retrospective cohort study of 12,594 patients tested for COVID. He wanted to answer the question, do antihypertensive medications increase the risk of COVID-19? He wanted to answer that question. And when he looked at the retrospective study, he saw that out of these 12,594, 46.8% had COVID positive and 17% were severe. Likewise, in these 12,594 patients, 34.6 were hypertensive, and out of these 34.6, 59% were COVID positive. That study was not designed whether hypertension can promote COVID, but this was just a statistical finding. But what he saw is that 24.6% of these positive hypertensive had severe illness. And after analysis, he showed no increased likelihood for COVID using antihypertensive drugs, including RAS blockers, beta blockers, and CCBs. And likewise, there was no difference in the risk of developing the severe COVID infection using any of these antihypertensives. This is an example showing to you that the likelihood of a positive COVID test is not related to the drugs. As you can see here, COVID negative, COVID treated with medication, and these are COVID patients not treated with medications. And you can see they have almost the same figures with the ACE inhibitor, the ARB, combined beta blockers, calcium blocker, and thiazide diuretics. So we don't have to be afraid that the drugs for hypertension can increase the likelihood of COVID. Now, for my last agenda, I will run through the different guidelines during the pandemic from the Asian Pacific perspective. Of course, we start off with the American Heart, the Heart Failure Society, and the American College of Cardiology statement telling us that they have issued in March 17, there are no experimental or clinical data demonstrating the beneficial adverse outcomes with using ACE inhibition. That's why we need more studies. Likewise, the European Society of Cardiology also stated there is lack of any evidence supporting the harmful effect of the RAS blockers, and they recommend that we should continue the treatment of the usual drugs because there is no clinical evidence that these drugs can harm the patient. Now, there is this statement from China Society of Cardiology telling us that we should continue the drugs, and those who are infected with SARS-CoV should continue even the drugs, and regardless of the SARS-CoV infection, if there is overt change in blood pressure, then we should put more attention. If there is severe infection, respiratory support, then we should individualize the use of ACE and ARB in the COVID patients. Even in Malaysia, they echoed the position of the European Society of Cardiology that there's lack of evidence on the use of RAS blocker. So we should continue the use of these RAS blockers. Korean society also tells us there is no evidence of RAS inhibitors harming COVID-19 patients, and therefore we should continue and maintain these drugs. The Taiwan society also tells us to continue our RAS blockers, inhibitors, because there is no evidence. But in case of shock or severe disease, then we have to discontinue the BP lowering drugs. Even in Indonesia, they tell us continue, do not hesitate the use of the RAS blocker. In our country, the Philippine Heart Association and the Society in Hypertension also tell you, continue the RAS blockers. Continue the RAS blockers because they give reasonable benefit for our patient. We even have our Asia Pacific organization called the Hope Asia Network telling us that the pre-existing hypertension may be common in COVID, but there's little evidence that it can promote COVID among hypertensives. And then is it safe to continue? Yes, as of May 20, there's no data showing harm using these drugs, and therefore we should continue. And our Hope study group also recommend that we use biomarkers, in order to monitor our patients. And these are the biomarkers, the troponins for myocardial injury, D-dimer, the aminoterminal or the anti-BNP, the creatinine, C-reactive, and then the IL-6 for cytokine storm. So for clinical practice guidelines, our Hope Asia group tells us that the hypertensive patients, older patients, are at high risk, and they're more likely to develop myocardial injury and severe infection. Diabetes are likewise have to be closely monitored. They should be determined the biomarkers and also monitor the oxygen saturation of the patients. And the progression of COVID and the cardiovascular status should be monitored closely, looking at the blood pressure, and then the hypertensive drug should be continued, but monitoring any hypotension or kidney injury. And in unmedicated COVID-19, we look at comorbidity, and then they can be treated with CCB first if we are concerned about RAS blockers. And then the physician should be aware of the physical manifestation of stress for this patient. So last, let's go back to our patient. What will be our decision on this patient with COVID? Of course, we hospitalize. We start the treatment with COVID. We should continue the aspirin. And I think you will agree with me, you continue with the telmisartan because of lack of evidence of harm. So my colleagues, let me summarize that COVID-19 causes multiple organ damage, causing it to, making it a multi-organ tropism. And hypertension is the most common comorbidity. Older age group and the presence of comorbidities increase the risk of death in COVID-19. The ACE2 is a receptor that allows the virus to enter the cells, and all the RAS blocker are suggested to upregulate ACE2. No evidence yet on the harm. There are no evidence that RAS blockers should be aggravating COVID, and therefore we should continue. And the Asia Pacific perspective tells us that the RAS blocker should not be discontinued because of the benefit that we get from it. With that, I would like to thank you all for your attention.
Wonderful, wonderful, Dr. Sison. That was an amazing lecture, very comprehensive, and covered, I guess, everything. Now I'd like to take a quick question. Dr. Sison, maybe you'd like to stop share your slides.
Okay, thank you.
Yeah. So can I ask Professor Koji, I think to just re-summarize, I think, do you
Yes.
believe that the current evidence is strong enough to refute the association of ACE or ARB interaction in the RAS system for the ACE2 receptor entry?
After,
Yeah, maybe
yeah,
you
okay.
can make some comments.
Okay, thank you very much, Jack. And it's very important question and also important lecture. And there is association between ACE inhibitor ARB and poor prognosis of COVID-19, or there is no association between them. But there are many papers on that. But that is just the association. It does not always mean the cause-effect relationship. I mean that even though there is an association or not, it does not always mean ACE inhibitor or ARB exert beneficial effect or harmful effect on the prognosis of COVID-19. So it's very difficult to make a conclusion. But just the speculation, ACE2 is a protective molecule, and well, ACE2 also serve as a receptor for COVID-19. But in experimental model, overexpression of ACE2 will protect the heart and the lung against the pneumonia. So some people claim that ACE inhibitor will be the beneficial, but it's not conclusive because it just most of the papers are just investigating the association. We need a prospective study to see whether the ACE inhibitor and placebo and to see the prognosis will better or bad by prospective study. So at present, there's no conclusion. So, but the comment by George, all of the comment is right.
Thanks. I think very valid comments. And just to recap, there's no indication of harm now for using RAS inhibitors in this subgroup. And to also emphasize, more importantly, do not stop it, especially in a patient with reduced EF heart failure subgroup beyond hypertension. So that's even more important to reduce hospitalization unnecessarily by stopping this group of medication. The other thing to emphasize that there are ongoing trials trying to randomize using losartan, even some CCBs, to see whether it helps with COVID-19 infection prognosis. So before those trials come out, we do not know whether it's beneficial or harmful. And truly, I think the current evidence, I'm quite happy for what Sison presented, saying that there's no indication of harm. Can I now ask the rest of the participants and the panel, what epidemiological highlight or pointers you would like to tell your audience, whether it's coming from Mongolia, Taiwan, Bangladesh, or Philippines? For your country, do you have any observations about COVID-19 and hypertension? The thing that I always had question on, beyond all the risk factors you presented, was a male.
From Bangladesh, there is some short, not the very big studies, but the hospital-based studies where the AC inhibitors or ARBs are being continued in the hypertensive patients without any adverse outcome in comparison with the other antihypertensive or the other no antihypertensive. So it is also in collaboration with the other findings of the different parts of the world. The question is what the Dr. Kozi said, that the trial that was undertaking to see whether it is beneficial or not. It is that will be a very good finding. If it is beneficial, then we can suggest the use of the RAS inhibitors to every patient of the COVID-19. So that is the question. But from Bangladesh point of view, we are very happy to continue the RAS inhibitors when there is indicated, even in the heart failure patients or the others having the COVID-19.
Jack, can I add to that? In the Philippines, we are following our local guideline, and we are in agreement to continue all the RAS blockers that we are using because it benefited our patients with heart failure, post-MI, etc. So we are not afraid about this concept of RAS blockers harming our patients. So very much are in liberty to use, as usual, the RAS inhibitors in our cardiology practice.
I'm also interested to hear from Mongolia.
Yes.
What is the
Hello,
mortality rate like in Mongolia, and what is the situation of COVID-19 in your country?
Well, first, hello everybody. And in regard of COVID-19, we have very limited cases because we have, as yesterday I mentioned, we have closed our border in January of this year. So we have only little more than 300 cases, which are not severe patients. We have no deaths yet, fortunately. And all the patients are treated in the infectious disease hospital. And in regard of the AC inhibitors in the hypertension treatment, we continue as it is. Those patients which having first among 300 patients, not many patients with hypertension. So we try to continue as they were receiving as antihypertensive treatments. So it's too early to say that there is a comparison benefit on that, but we are happy to follow APSC's guidelines and other guidelines on continuation of RAS.
You are in a very good place to have just 300 cases. Please do keep that up. And we hope the vaccine comes to you before you can open your borders again. I hope you open it soon anyway. Can I ask Dr.
Sometimes in one center in Bangladesh, there is more than 300 patients. Only one center, COVID dedicated center. But the situation has changed now. But during the May, June, July, there is such was the case that in a single center, there's more than 300 cases in Dhaka city. So
Yes,
very lucky for the Mongolians.
I think in more populous countries, whether it's India or Bangladesh, it's amazing the numbers. Can I ask Dr. Professor Kishi? There's also an observation beyond what Sison presented that there's also a male predominance of COVID-19 cases. The male gender seems to be one factor as well. Do you have any speculation about why this may be the case?
Very good, but difficult question for me. However, sorry, I'm not sure. I do not have. I do not have the adequate answer to your question. Sorry.
No problem. I don't know whether anyone has any other thoughts, because over and beyond hypertension, ischemic heart disease, diabetes, lung disease. You see that more males do get COVID-19 compared to females, and they tend to do also worse in some ways. But I'm not too sure what's the reason. Prof. Koji?
Yes, I have one comment on that. Actually, the ACE2 is a receptor and protective, and the ACE2 gene is localized in the X chromosome. So the female have more ACE2 expression, so which might be protective against the COVID-19. So one of the reasons may be the quantity of ACE2 is different between men and women.
So thanks, Prof. There's one postulation that some people have mentioned, that the X chromosome is double protective because of the ACE2 gene. And it's not because males are less hygienic. So I'd like to clarify that. So I think, is there any other comments for any of the other panelists, including the Taiwan side, Prof. Lin? Any last comments before the next lecture on hypertension and COVID-19? If there's no further comments, maybe we can move on to the second lecture of the day by Professor Takuya Kishi. And he's going to speak to us on blood pressure variability problems in hypertension management.
Thank you, Chairpersons. I'm Takuya Kishi. At first, can you hear my voice? Okay.
Yeah, it's good. We can see and hear clearly.
title slide, okay?
Slides are good as well. Please go ahead.
Thank you. Now start. I will try to hurry up my presentations. Again, my name is Takeya Kishi from Japan. My university and lab are located at Fukuoka of the Kyushu Island in Japan. Kyushu Island is the west side of Japan. So from here, the Chinese Taipei is equal distance from here to Tokyo. So I like to go to the Chinese Taipei and if possible, I'd like to meeting you. Now, it's my great pleasure to do my presentation in this APC class forum in cardiovascular disease. So in this new developments and breakthrough in hypertension treatment part 1, I'll talk about the treatment strategy for hypertension with blood pressures variabilities. Now, let's start. This slide is today's goal. So although blood pressure's variability is worsening in hypertension, it has not been established as a therapeutic target. Blood pressure variability is mainly determined by the bell reflex systems. The central arc of bell reflex system is disrupted in early phase of hypertension. The device bell reflex system is expected to improve the impaired blood pressure variabilities independent of blood pressure levels. Now in Japan, 350,000 people died due to the cardiovascular diseases. This number is maybe 25% of all cause of death in Japan. In Japan, among the various factors for death, as you can see, the hypertension-induced cardiovascular diseases, as the light blue bars, is the worst, more than the smoking-induced cancers, as the navy colors. So we should treat more and more to hypertension. However, various and many beneficial anti-hypertension drugs are available in Japan and worldwide. So what is the unmet needs, the therapeutic target for the hypertension? That is the variabilities, what we call the qualities of the hypertension. As you can see in this slide, this is a schema from the guidance textbook medical physiologist. The multiple factors in various time constants is determines the arterial pressures. In y-axis indicates the power to change the blood pressures. The x-axis indicates the time constant from seconds to days. Among these various factors, as you can see, it's the right side. This red line indicates the renal blood pressure natural risk relationships. So the renal blood pressures natural risk determines the basal level of the blood pressures. In constant, at the left side, the black line indicates the baroreceptors factors. The baroreceptors determine the blood pressure variabilities in the second orders. Blood pressure variabilities is worsened with the progression of the hypertension or age or vascular aging or vascular resistance or vascular remodeling. So as you can see from left to right side, the increase of the blood pressures with the disruption of the blood pressure variabilities cause the cardiovascular events. So circulatory homeostasis is mediated by multiple organs, as you know. So who is the center? Of course, the brains. The brain determines the sympathetic activities mainly by bell reflex systems. This slide shows the bell reflex systems. At the left side, the brain determines and sense the blood pressures and determines the sympathetic outflows. The sympathetic activities go into the peripheral arc, peripheral organs, and produce the blood pressures. This blood pressures go into the brains. This cycle length is just around 5 to 7 seconds. As you can see on the right upper side, the brain, the central arc of the red lines indicates that the blood pressure increase, sympathetic nerve is decreased. the blood pressure is decreased, the sympathetic activities is increased. However, in the peripheral arc, the sympathetic activities increase, the blood pressure is increased. So combined, this central arc and the peripheral arc is the right lower panels. So this is a normal condition. So how about the changes in the hypertension? In the hypertensions, the central arc, not the peripheral arc, central arc of the blood reflex system is shifted to the right upward. So the blood pressure is increased, the sympathetic nerves increase, indicates the set point. So the varicose fera disrupts the blood pressure variabilities from green to red. Green is the normal blood pressure changes, and the red indicates the varicose feras. This is my papers. This one showed. This paper shows that the worsened the short-term blood pressure variabilities due to the shift of the central arc of the blood reflex controls. Circulating homeostasis mediated with multi-organ system is also disrupted, and blood pressure is stabilization of the blood pressure is disrupted. Moreover, as you can see, the left upper panels, the dot line indicates normal condition, and the black line indicates the varicose ferrous. This is the normal part kidney and normal vasculars. As you can see, the varicose ferrous by the break of the baroreceptors at the neck, varicose ferrous worsens the blood pressure variabilities. However, please look at the left lower side. This is the salt overload and varicose ferrous. The salt overload and varicose ferrous disrupt the blood pressure variabilities more. Moreover, the renal, in the aspects of the renal pressure naturalist relationships, there is two input into the kidney. One is the blood pressures and one is the sympathetic activities. The blood pressure is increased, the urine volume is increased. However, the sympathetic activity is increased, the urine volume is decreased. So there is two input into the blood pressure and blood pressure naturalist relationships. So this is my study, but blood pressure and blood reflex factors equally regulate the urine volumes. So the varicose fera worsens the renal pressure naturalist, as you can see, it's red lines. So the varicose ferras cause the worsens the blood pressure variabilities, but also the baseline of the blood pressure because renal pressure natural relationship is worsened. So I can see I would like to show that the varicose ferrous is the major factor of the hypertension, not only in the blood pressure variabilities, but also the renal pressure natural relationship is worsened. So how to treat? This is one of the recommendations. Afferent vagal stimulations improves the blood reflex central arc from A to B. From A to B. A is the hypertension and B is the normal conditions. The afferent vagal stimulation is pernicious. How should we do the afferent vagal stimulations? One is the device therapy, but also the other is the dilatation of the lung, use of the muscles, use of the gastrointestinal organs, and the other is salt restrictions. So the salt intake restrictions, the exercise, and happy life and happy meals cause the stimulation of the afferent vagal, not afferent, afferent vagal stimulations, and improves the varicose ferrous, central arc of the varicose ferrous, and maybe improves the blood pressure's variabilities. So the legend Hippocrates says that walking is the best medicine to us human beings. That's right. However, unfortunately, the blood pressure variabilities do not have good evidence as therapeutic target and hypertension. So why? Because blood pressure variety is improved by the blood pressure lowering therapies. So we can assess the effect of the blood pressure, the improvement of blood pressure variability itself, independent of the blood pressure lowering effect. So various guidelines is worldwide, is ESC or ACH or HA or SC or Japanese Circulation Societies. There is no clear descriptions about the blood pressure variabilities as the therapeutic target in hypertension. However, recently, as you know, the device therapy is progressive. One is the barrel-reflex activations. Of course, the barrel-reflex activations improve the barrel-reflex failures directories. However, now the barrel-reflex activations device is not the last result because this device cannot sense the blood pressures. So with the artificial barrel-reflex system, our mathematical models predict blood pressure with barrel failures and normals. As you can see, the left upper points, this is animal study, but this is a real normal blood pressures. Our mathematical model predict the barrel failure blood pressure variabilities from real normal variabilities to predicted barrel failures. In contrast, our mathematical model predict normal blood pressure varieties from the real barrel-reflex failures blood pressure varieties. Recently, our colleagues indicate that smart barrel-reflex activation system, as you can see, is strikingly attenuate blood pressure varieties independent of the blood pressure levels. In addition, we should focus deep insight into the brains. In this decade, I have demonstrated that our human has the vasomotor centers in the brainstem. This is the rostral ventral lateral medullus, what we call alveolar length. In this alveolar length, the AT1 receptors induce the reactive oxygen species, increase the sympathetic activities. So in animal models, we have demonstrated that the directly block to the AT1 receptors into the alveolar locally decrease the blood pressures, decrease the sympathetic activities, and improve the blood pressure variabilities. So we are now trying to make a new drug to affect the alveolar directories. So now this is the last slide to discuss. So although the blood pressure variabilities is worsened in hypertension, it has not been established as a therapeutic target in the available guidelines for the hypertension. However, the blood pressure varieties is mainly determined by barrel-reflex system. So central arc of the barrel-reflex system is disrupted in early phase of hypertension. So the device therapies for barrel-reflex system is expected to improve the impaired blood pressure variabilities independent of blood pressure levels. So in future clinical further experiment, we should try to assess the improvements or interventions to the blood pressure variabilities in hypertension has benefit or prevent the future cardiovascular events or not. Oh, thank you.
Thanks, thanks, Prof. Kishi. Very interesting topic they presented. I must admit, when it comes to this depth of knowledge, I'm not a domain expert. But I have lots of questions for you. Maybe I can start off with questions by others. Anyone has any questions for Dr. Kishi before I start?
Okay, can I start the question?
Yes, please.
Yes, thank you very much, Dr. Kishi. Very excellent lecture. I'm very much interested in your lecture. And you said that the blood pressure variability may not be established as a risk factor, but I think that there are several evidence that short-term calcium antagonists worsen the heart failure, but a long-acting calcium antagonist will be safe for heart failure. So that may be the indirect evidence that the blood pressure variability will worsen the prognosis of heart failure. By the way, so you said that salt diet or exercise will improve the blood pressure variability. It is very important. And then what will be the risk factor for the blood pressure variability? For example, diabetes or aging or mental stress or, yes, please.
Okay, thank you. I think you recommended mental stress or diabetes or salt intake or mental stress, diabetes or smoking. All of them is a risk for the blood pressure disruption of the blood pressure variabilities. Especially my clinical work indicates that smoking and obesity and diabetes in younger peoples cause the disruption of the blood pressure varieties.
Thank you. And any other questions from the other panelists?
Just may I have one?
Yes, please.
Is there, at the present moment, is there any therapeutic agent that may we advocate for these patients? Either the long-acting antihypertensive will be better for them, or if we use the short-acting antihypertensive in the multiple doses. What is the rationality of using the antihypertensive in these patients?
Sorry, I cannot hear the first part of.
The thing is that what we may suggest at the present moment, any therapeutic agent which might be proven to be superior to the other agent. As for example, if we can give him or her the long-acting antihypertensive, is it better, or we should give the short-acting antihypertensive in the multiple doses? Which one would be better for the case of these blood pressure variability cases?
Thank you. Short-term blockers or beta blockers sometimes worsen the blood pressure varieties. Supposedly, short-term beta blockers worsen the blood pressure varieties. So, in the calcium channel blockers, we should do long terms, and in diuresis, we should do long terms. And my research indicates that the renin-angiotensin system inhibitors has the neutral effects. Not worsen the blood pressure varieties. So we should use the long-term calcium channel blockers, diuresis, and renin-angiotensin system inhibitors, superior to the beta blockers and the short-term calcium channel blockers.
Any other questions? Yeah, Siton?
Yeah. I want to be clarified, Dr. Kishi. Your talk is nice. About the sodium, if I get it right, that if there is sodium overload or salt overload, it has an effect on blood pressure variability. Can you again explain that part?
Thank you. Sodium overload increases the stress volumes in the human systems. So stress volume indicates the intravascular volumes. The intravascular volume is the preload to the heart. So the increase the preload, the cardiac output is increased, and blood pressures increase independent of the vascular stiffness. So sodium intake, sodium overload worsens the blood pressure varieties independent of the blood pressure levels.
So therefore, diuretic can be something that.
Yes, that's right. So the diuresis improves the short-term blood pressure varieties in various clinical works.
So thank you. Any questions? If not, I may start my questions and comments. So I think the first thing I want to emphasize is that I love the data shown by Prof. Kishi about the impact of hypertension, especially in the East Asian cohort. Hypertension is a real killer in Japan, Korea, China, and the northern Eastern Asian countries. while diabetes is a huge problem, is our Southeast Asian cohort because of early onset CAD. So I think, but it kills and it's difficult to control. My observation about this baroreceptor reflex, my own comment is that I'm not too sure whether it's a marker of efficacy or is it a disease by itself. For example, you say excess salt, maybe obstructive sleep apnea, maybe other mechanism. It's just a reflection of disease and reaction to hypertension causes rather than by itself is abnormal. And I think it's also not easy to establish normal range. And should you call the upper range 80th percentile, 99th percentile before it's abnormal? And what is the normal range in elderly versus young versus anxious patient? I think it's very difficult, and different loading conditions may affect baroreceptor. I think many years ago, there was actually postulated device therapy to use baroreceptor modulating devices to target blood pressure control, but that has seemed to have fallen out of favor. I suspect the data is not really strong. I wonder whether have you have any data saying that this could be an index of device therapy success, whether it's direct or indirect, like renal denervation, whether it does affect baroreceptor, blood pressure variability, and what is the evidence to say that the variability kills more than just a ambulatory blood pressure measurement, and what is the variability range before it be considered significant? For example, you come to the office, a lot of white coat hypertension. Is that because there's also a lot of debate saying that white coat is not benign, and whether that's also a reflection of baroreceptor variability as well. I know a lot of comments and questions. Maybe you take whichever track you like to answer, Prof.
Yeah, your comments is quite interesting for me because that is a problem with the research of the pressure varieties from markers, and we have known the interventional tools and how to sense and assess the blood pressure varieties in clinical work. Of course, blood reflex sensitivity is not the best critical markers to the blood pressure varieties. So your comment is encouraged me to do my research in future. Thank you.
So I maybe one suggestion, I would love it that if you have a patient I suspect is white coat hypertension, instead of me doing just an ambulatory blood pressure, maybe you can have some marker to say that this patient has excessive baroreceptor variability or blood pressure variability in the white coat hypertension cohort. I think in a lot of things, hypertension is controversial, even excessive salt intake. I've seen debates saying that some people don't believe that excessive salt intake increases high blood pressure. So too many controversies for me to handle. Any other comments or questions from the other panelists? Any comments? Prof. Lin from Taiwan, are you still on the line? Prof. Lin is also an expert on this topic. I wonder whether he has any comments to make.
I think actually the reason I choose this topic is it's really quite difficult in clinical practice. It's say the white coat hypertension, mass hypertension.
Yes.
Sometimes it's difficult to say what is called variability. That's why we don't have much evidence on this topic. Actually, our real serious problem is in Taiwan, just like Japan. We are quite an aged society, and all age people, they have serious problem, postural hypertension,
Yes.
and
Yes.
also a lot of blood pressure variability. Actually, I have the same question as Jack. How do you measure the blood pressure variability? How do I choose the drugs? It's difficult. Sometimes it's really difficult.
Yes. Yes. Yes.
That's a COVID dilemma.
Yes. I think so. The short-time blood pressure parties can assess the by the wearable device in future. However, now the wearable device is everybody can use the wearable device for the blood pressures monitoring, and not the short-time blood pressure varieties, the season or visit to visit, or many blood pressure varieties in time constant. So today's I focus is the short-term blood pressure varieties. So your question is quite severe and difficult questions for me.
So thanks, Prof. Lin, for those wonderful comments as well. We are not asking difficult questions of you. We're just saying that actually this is a topic that is very exciting because no one knows. I hope some of your research can then answer questions in terms of variability, in terms of mass hypertension, in terms of how to integrate this piece with our ambulatory blood pressure or office blood pressure measurement. I think all this, if you can bring it to clinical practice in a well thought out way and define normality and markers, this will help especially our aging population in East Asia where there's a lot of variability. And what is the ideal agent for this group of patients? So we actually applaud you for your ongoing work, and please work harder.
Yeah.
Too many questions to answer. So I think if any other last questions for the first two speakers? Any comments or questions? If not, I'm going to pass over the chairmanship to Professor Koji Hasegawa, who's also a good friend of mine from the Kyoto Medical Center from Japan. He's the immediate past president of the IICP, and he's going to chair the next two lectures. Prof. Koji.
Okay, thank you very much, Jack. And I'm Koji from Japan. I'm going to take the later half of the excellent two speakers. The one topic is hypertension in pregnancy. The other topic is hypertension in chronic kidney disease. Then I'm going to introduce Dr. Mungchon Meg Daguba. I think I had better call you Mongo. She comes from Mongolu. She is the director of the cardiovascular center, Shastin Central Hospital. She is also the president of the Mongol Society of Cardiologists and fellow of the European Society of Cardiology. She's going to speak treatment strategy for hypertension disorders in pregnancy. Dear Mongo, please.
Thank you. Thank you. I'm going to share my, I see the message that host disabled participants screen sharing. Could you please allow me to share my screen?
Can we allow Prof. Mongo to share screen? Yeah, can you try again, Prof? See whether it's possible.
Okay, I'm very honored to attend this important symposium, and I would like to talk today. My topic is treatment strategy on during pregnancy.
Can you share screen again and see?
Right now, it should be okay.
Okay. Okay, just a moment.
No problem, no worries. We don't want to increase the blood pressure variability here, so just take it easy.
Okay. Let me adjust a little bit to make it smooth. Okay, so I hope it's visible now. Is it okay?
Yes,
Like
it's okay. Yeah.
Okay, good. So this is I'm going to, generally the hypertension during pregnancy called to be the hypertension disorders in pregnancy, HDP. And this is a common pathology because it is complicating 5 to 10% of pregnancies worldwide. And it remains a major cause of maternal, perinatal, also fetal, neonatal morbidity and mortality. And this pathology is also increasing year by year. Looking to, according to the latest, one of the latest data that if you compare in the United States, if you compare in 1987 to 2004, the HDP is increased by more than 25%. So on top of that, on top of the complication of maternal side and neonatal side, the HDP is becoming a serious cause of the woman's cardiovascular disease risk. It is well established that women with a history of HDP have a markedly higher risk of future cardiovascular disease. For example, here it's shown that cardiovascular chronic hypertension, women with a history of HDP has the risk, relative risk of almost 2 for hypertension and 2.5 for coronary heart disease. If you look to the prevalence in worldwide, I could withdraw it from several recently issued publications that there are the data is available but not consistent, and also, for example, like in our country in Mongolia, only preeclampsia is solely well registered, while others are lagging. Let me quickly go through a definition, classification of the HDP. It, according to the ESC guidelines, it includes the 5 subcategories. Pre-existing hypertension, when the hypertension starts before 20 weeks of gestation, and the gestational hypertension, if it develops after 20 weeks, and a chronic hypertension with superimposed preeclampsia, pre-existing hypertension plus superimposed gestational hypertension with proteinuria, and alternative preeclampsia, and alternatively unclassified hypertension. If you look to the subcategories, sorry, I just want to hide. Okay. If you look to subcategories, mostly predominant is gestational hypertension and preeclampsia, accounting 5 to 7% of the disease. The general management of on the diagnosis is including pre-pregnancy counseling, blood pressure measurement. In this case, it's optimal to take blood pressure in the office, or if it's possible, ambulatory blood pressure monitoring and home monitoring is preferable, and all the investigations, which is usually in all the guidelines. Preeclampsia, I would like to highlight preeclampsia and gestational hypertension a little bit, because these categories are most complicated part of these hypertension disorders of during pregnancy, because it not only because it's complication, but also it implicates in the woman's further life. Women with preeclampsia have 71% increased risk of cardiovascular disease mortality compared to normotensives, and 2.5-fold increase of coronary artery disease and 4-fold increase of heart failure compared with the normal cohort. And here you can see preeclampsia and eclampsia is the having even though the etiology is not completely clear, but there are certain factors playing a role, like metabolic syndromes, obesity, diabetes, hypertension. But also, if gestational hypertension and preeclampsia combined with this maternal complications and neonatal complications like small gestational age at birth, preterm delivery, it really complicates and increase the cardiovascular risk in postnatal period of woman's life. Here you can see that the combination of these combination of these categories are increasing, markedly increasing not only overall cardiovascular risk, and also hypertension, coronary artery disease, stroke, and heart failure, and general mortality in this. Okay, so that's why important to consider how to on the prevention of preeclampsia. In most of the guidelines stipulating that aspirin intake in a low dose, 75 to 165 milligrams per day, is currently the only drug recommended by professional societies for prevention of preeclampsia. And there are other regular exercises, low molecular heparin in early severe preeclampsia, and the calcium supplementation is also recommended. These are multiple guidelines on the management of hypertension in pregnancy exist. These are the last 2 years only. There are many, and the number of studies issued and published among them also. The chronic hypertension in pregnancy project is ongoing, and it's going to complete in 2021. And there are also, the professor mentioned earlier that the SARS-CoV study with the pregnancy is issued recently. However, the number of RCT and systematic reviews were conducted, updated, and certain conditions still exist. However, no clear consensus currently exists on the optimal blood pressure threshold at which to initiate treatment and the target blood pressure to achieve. Let me show you comparison of clinical guidelines on definition, treatment threshold, and target blood pressure. As you can see, in ESC guidelines, the definition of hypertensive disorders of pregnancy, there are 5: pre-existing hypertension, gestational hypertension, preeclampsia, pre-existing hypertension with superimposed preeclampsia, and antenatally classified hypertension. While other guidelines, for example, in American College of Obstetricians and Gynecologists are recommending 4 classifications, and the National Institute of Healthcare is recommending 4 definitions of this disease. If you look to what is recommending in about the threshold of blood pressure to initiate antihypertensive drugs are also different. According to the European guidelines, if there is a gestational hypertension, pre-existing hypertension, and organ damage, pharmacological treatment has to start equal and or more than 140 and 90 millimeter mercury. Otherwise, if there is no supporting, comorbidities, start above 150 and 95. And emergent treatment and hospitalization needed in case of more than 170 and 110 millimeter mercury. And meanwhile, there are some guidelines even not clearly issued when to threshold of blood pressure when to start the treatment. If you look to the target blood pressure to aim, there are still missing clear recommendation what will be the target blood pressure to aim. Also, same statement in regard of sorry, it's not clear. Okay, it's not clear. Comparison clinical guidelines, first line and second line treatment also a little bit different, but here most of the guidelines recommending as a first line treatment for the non-severe hypertension, the same group of medicines like methyldopa, labetalol, and nifedipine, but a little bit differing in the severe and second line treatment. There are, in regard of when to initiate pharmacological treatment, in the Cochrane Collaboration System Review, covered 49 randomized trials issued and revealed that the initiation of antihypertensive therapy in a mild and moderate hypertension, halving the risk of the progression to severe hypertension. This is very good statements to consider. And this study also showed that meanwhile of that, no significant reduction of maternal and fetal complications were observed. In a study, randomized clinical trial, control of hypertension in pregnancy, there was also interesting results. This showed that the CHIPS RCT proved treatment benefit in tight versus less tight control of hypertension in pregnancy. Tight means targeted diastolic blood pressure aiming to 85 millimeter mercury, and the less tight group arm was targeting around 100 millimeter mercury, respectively. Among this less tight group, the incidence of severe hypertension was high. In most hoc analysis of the CHIPS trial, the occurrence of severe hypertension was associated with the increased risk of pregnancy loss, the need for high-level neonatal care, low birth weight, and preterm delivery. Okay, in the management of pregnancy, definitely the pregnant woman with the hypertensive disease has to be cared by the multidisciplinary team, cardio-obstetric team, including obstetrician, cardiologist, anesthesiologist, and neurologist, even GPs. And non-pharmacological treatment in HTP is also important, but in several studies, even though several studies are showing that minimal or low impact on lowering blood pressure, that regular exercise may improve vascular function and prevent preeclampsia needs to be taken in consideration. In regard to pharmacological treatment, this slide from American Heart Association guideline is nicely illustrated that about the safety in the preferred drugs, medical treatment during the pregnancy. As we all see that ARB, AC inhibitors are contraindicated during pregnancy because of their teratogenic effect. But recently, some studies started to show that it's also needs more investigation. Otherwise, beta blockers, the alpha agonists, calcium channel blockers, and vasodilatators are commonly used in hypertension. We will discuss it later. And before starting pharmacological treatment, the potential risk of drugs and possible benefit must be weighted well beforehand. This is recommended also by guidelines. And recent Canadian guidelines showing that nicely showed that during the pregnancy, first-line treatment, second-line treatment, and the medication with the So still, we can see in regard of the first line, oral drugs can be methyldopa, labetalol, and long-acting nifedipine, and while the second line can be clonidine, hydralazine, and thiazide diuretics. In the first line treatment for non-severe hypertensive disorders, most of the studies are started to trend to show that nifedipine, oral nifedipine, is suitable, is available, and affordable, and also having good results in the non-severe hypertensive disorders. And the dosage will be 30 to 100 milligram per day. And here in the comment column, you can see what is the recommended for what are the difference from all those medications, and adverse effects are also stated here. And a European Society of European Society's guideline recently recommended that when you choose a pharmacological treatment, should consider not only FDA's category of safety, it has to be also considered other guidelines recommendation. So nifedipine, labetalol, and methyldopa is really first-line choice for non-severe HDB, while the second-line treatment can be hydralazine and thiazide diuretics. The first-line treatment on severe hypertensive disorders, including also nifedipine oral prescription and labetalol intravenous prescription because of the severity. And central alpha agonists like methyldopa also can be used, and hydralazine as well as. There are some studies comparing hydralazine with labetalol, the methyldopa, but there are not much difference in those studies. What to keep in mind in emergency department is expeditious triage and treatment within 30 to 60 minutes of confirmed severe hypertension, which means more than 160 and 110 millimeter mercury, persistent more than 15 minutes, should be initiated to reduce the risk of maternal heart failure, myocardial ischemia, and stroke, and renal disease. And blood pressure needs to be reduced to less than 160, 110 millimeter mercury, with initial reduction of less than 25% in the first hours of treatment. In contrast, if there is end organ complications such as pulmonary edema or acute kidney injury, it has to be emergent. The first-line treatment of severe hypertension also most commonly involves magnesium sulfate indication. In regard of magnesium sulfate indication, the dosage and what to care in the protocol was nicely showed in the clinical practice guidelines of New Zealand 2018, I guess. Okay, another important point in management of HDP is postpartum period. Postpartum hypertension persists. Any of the recommended drugs are continued, except methyldopa, because of the methyldopa's influence as postpartum depression to women. It should be avoided. And in regard of the breastfeeding women, all the medications are in breast milk in a low concentration, but needs to be careful in regard of atenolol, propranolol, nifedipine due to high concentration in milk, and also prefer long-acting cardio CCBs. AC inhibitors might cause hypertension, particularly in premature infant, needs to be taken into account. And as women are with hypertensive disorders during pregnancy, can be the at high risk of development of further development of cardiovascular disease, especially hypertension. The woman recommended to screen for hypertension in postpartum period well, and if there is a high blood pressure more than 150/100, then initiate pharmacological treatment at 2 weeks after delivery, and has to be followed by physicians. Prevention of the cardiovascular disease, according to prevention in postpartum and cardiovascular disease is well illustrated in American Heart Association's statements. What about HDP in a patient with infected with SARS-CoV-2? And definitely it's a complicated issue because of already pregnancy was hormonal change in a woman, but on top of that, hypertension plus immunological status is influencing and making a woman to be fragile for the COVID transmission. So my conclusion is to most importantly to prevent from the contracting COVID SARS-2 is important. And what to consider in the treatment, the recommended the pharmacological treatment, how is interacting with the antiviral drugs are shown here in this slide. And we have to take care about the calcium channel blockers, especially with the lopinavir and the ritonavir, expected to be toxic during the pregnancy. And also in regard of beta blockers, safely administered in women with HDP who infected by SARS-CoV, but low molecular heparin seems to mitigate the pulmonary coagulopathy often promulgated by virus. And vitamins are listed in the last column. Take-home messages from my presentation. The threshold to initiate antihypertensive treatment is between 140, above 140, 90 in women with gestational hypertension, pre-existing hypertension, and organ damage, and for other women above 160 and 110 millimeter mercury. An early initiation is associated with the low risk progress to severe hypertensive disorders. Systolic blood pressure more than 170 and diastolic blood pressure more than 110 in a pregnant woman is emergency. Is indication for emergency hospitalization and for urgent pharmacological treatment. Non-pharmacological treatment recommended throughout pregnancy period. Before initiate antihypertensive treatment, check drugs and safety is crucial. And oral calcium channel blockers, nifedipine, nicardipine, beta blockers, labetalol, methyldopa is recommended as first-line treatment for non-severe hypertensive disorders. Sublingual or oral nifedipine, IV labetalol, and IV hydralazine are recommended as first-line treatment for severe hypertensive disorders. And target blood pressure should be between 150/100 and 110/80 millimeter mercury, and the maternal hypertension-related placental hyperperfusion remain the real concern. Therefore, blood pressure should be reduced at the rate of approximately 1 hour, during 1 hour, 25%, followed by a slower rate for targeting blood pressure. Severe hypertension associated with end organ complications such as pulmonary edema or acute kidney injury is considered an emergency, and the blood pressure needs to be decreased much faster. Magnesium sulfate reduces the risk of women having further seizures, not to stop seizures. Low-dose aspirin recommended for all pregnant women at high risk for preeclampsia can start and administered at 12 weeks to 36 weeks of gestational age. RAS inhibitors, AC and ARBs, are teratogenic and contraindicated during pregnancy. Methyl-DOPA recommended discontinued and replaced by other drugs in the postpartum period, and it's associated with the postpartum depression. All antihypertensive excreted into the breast milk in low concentration. Hypertensive disorder is now independent risk factor of cardiovascular disease. It has to be taken in consideration. Thank you very much.
Thank you very much for your excellent lecture, Mongo. And yes, hypertension during pregnancy is a very important risk factor for both mother and children. And I do not think so many cardiologists are familiar in this field. So I learned a lot from your lecture. Thank you very much. Just my quick question is that in the trial, the strict control of hypertension and not strict, less tight control of hypertension, you describe about the target blood pressure is diastolic blood pressure of less than 100 or less than 80. So is there any reason because of the blood flow to the organ is important? So is that the reason why you are targeting the diastolic blood pressure rather than the systolic blood pressure?
Yeah, this is the study which nicely demonstrated in two arms. One arm was targeting target diastolic blood pressure to 85 millimeter mercury, which considered to be the tight blood pressure control arm. The other arm was designed to less tight blood pressure control arm, which was considering that diastolic target blood pressure can be around 100 millimeter mercury. That was the study design, and this showed that the more tight group has a benefit in regard of reducing risk to progression to the severe hypertension during the pregnancy.
Okay, so maybe the diastolic blood pressure is one of the important control target. Thank you very much. Is there any comment or question from speakers?
One question.
Yes.
You mentioned about we already use nifedipine as the antihypertensive during the pregnancy, but can we use also the amlodipine or lecitipine, the other types of dihydroparatines and the non-dihydroparatin calcium channel blockers? Because sometimes the nifedipine is not, sometimes it is not good enough to control the blood pressure, or sometimes it is not available nowadays in our market. So we have to, sometimes we have to use the amlodipine or the lecitipine. These are the now widely used in the other cases of the hypertension. So should we use, can we use these agents safely?
In a meta-analysis, result of meta-analysis in a number of studies are showing that nifedipine, nicardipine is most studied among the pregnant woman indication for HTP, and it is considered to be most safest, best drug for dealing with the hypertensive disorders. But there are also some studies are suggesting that we still have to investigate the next generation of calcium channel blockers in this substance of people, in order to prove that it's the higher efficiency in such a group of patients. But currently, we can only refer that the most studied and proved that the safety of nifedipine and nicardipine.
Okay, is there any comment from President Jack and
so
George?
maybe
Yes.
Just one quick question. I always have this issue advising patients if they have antenatal hypertension, they want to get pregnant, and a lot of our young patients are on ACE and ARB. You do a conversion, and how do you usually switch? Do you usually switch therapy, or you
Yes,
don't advise it?
It's recommended to switch therapy. That's why it's important to pre-pregnancy counseling is crucial in order to have a less problem during the pregnancy. So the number of studies and the statements are recommending that screening pregnancy age women as much as in a large scale in order to identify who is hypertensive, who are not, and those who is a hypertensive woman needs to be counseled well, advised well in advance. If they are going planning to be pregnant, then it needs to be advised to switch drugs to other safer drugs.
Thank you.
Koji, may I ask a question? What is your take about the newer beta blockers like the nebivolol and carvedilol? Do you have any experience or?
Well, myself, no, not much experience, but we are in Mongolia. We are strictly advised from the Ministry of Health to follow up the WHO's guideline, where it says that labetalol is the first line beta blockers in this regard.
Thank you.
Dr. Kishi?
I've only I have a simple questions.
Okay.
How to detect the hypertension in pregnancies before the pregnancy? What is the best predictive markers or predictive clinical markers? Is there any surrogate marker, or is there any imaging? Do you comment?
Okay. Identifying women with pre-existing hypertension is more the problem of the organizations and even I would say governments' health policies in this way. So as hypertensive disorders of pregnancy is becoming a major independent risk factor for women's life to develop cardiovascular disease. It is a concern of the health institutions to screen young women before pregnancy or the pregnancy aged woman, the young women for probability or planning for the pregnancy and advice and pre-counsel well in advance by screening. In my opinion, this is the only way to, the screening is the only way to identify those who are at risk. Otherwise, also we should not forget about the risk of hypertension in generally, not only for women, and generally the hypertension is the first killer. It needs to be advocated well enough before pregnancy or after pregnancy. The whole population needs to have increased the knowledge about the hypertension and what are the risks it's taking with it. So this is the only answer from my side.
Thank you very much for your excellent lecture. This is a very important topic, but we do not have enough time. We need to learn more in future, and also we need more clinical trial to establish the evidence. Thank you very much for your excellent lecture, Dr. Mongo.
Thank you.
Okay, let's go to the last speaker. Last speaker is Professor Abdullah Al-Shafi Majund from Bangladesh Specialized Hospital, Dhaka, Bangladesh. And he is the honorary professor, Popular Medical College, and also he is a consultant cardiologist at the Bangladesh Specialized Hospital. He's gonna speak about the treatment strategy for hypertension in chronic kidney disease. Professor Abdullah, please.
Yeah, good morning. And I'm audible, no? Hello?
Okay, yes, please.
Oh, yeah. Good morning, and thank you, Dr. Kozi. Thank you, Dr. Tan, for inviting me. Thank you also to the Taiwan Cardiac Society, Dr. Lin, for extending invitation here. In the next few minutes, I'll be talking about the treatment strategy for hypertension in the chronic kidney disease. I have nothing to disclose. And though it appears to be very simple thing, one-dimensional, actually it is not, because neither the hypertension nor the chronic kidney disease denote a single or fixed entity. Rather, they belong to different shades. And hypertension is graded and stays according to the blood pressure by different bodies and societies. And frequently they are not consistent. And the method of measuring blood pressure, office blood pressure, ambulatory blood pressure, home blood pressure measuring, and also matters regarding the labeling as the person as the hypertensive. And chronic kidney disease is also not a single entity. It is also staged into 5 entities that are mostly acceptable by all the authors. Thus, management strategy of hypertension with chronic kidney disease entails the consideration of the level of the blood pressure along with the staging of the chronic kidney disease. The relationship between the hypertension and chronic kidney disease is interdependent. The hypertension causes the chronic disease, persistent hypertension results in the chronic kidney disease, and the chronic kidney disease by itself results in the rise of the blood pressure. So this problem was alerted as back as in 2009 to coin the slogan that the marriage between the chronic kidney disease and hypertension should be prevented. That was the message in 2009 on the World Kidney Day. And protect your kidneys, keep your pressure down, because the kidney is both a cause and victim of hypertension. So treatment of hypertension has become the most important intervention in the management of all forms of the chronic kidney disease. And the kidney disease is staged 1, 2, 3, 4, 5. 1 is actually the just kidney damage as evident by the proteinuria or the imaging or biopsy, but the GFR is normal, more than 90 ml. The stage 2 is the mildly decreased GFR, 60 to 90, and the moderately decreased the 30 to 59, and the severely decreased 15 to 29, and end stage renal failure or the kidney failure is less than 15. So usually in the practically, clinically, a persistent reduction in the GFR to less than 60 ml per minute per square 1.73 square meter is defined as the chronic kidney disease. And the classification of the hypertension, recently published hypertension guideline by the International Society of Hypertension, published just June 2020, they considers the normal as the less than 130 by 85, and high normal is 130, 139 to 85 to 89. And when the pressure is 140, above 140 and above 90 diastole, it is called the hypertension, and the graded 1 and 2. More than 160 and 100 is considered as the grade 2, and below that is the grade 1 hypertension. But see that they also set a criteria for the diagnosis of the hypertension based on the office, ambulatory, and the home blood pressure. The office blood pressure is the less than 140 by 90 is considered as the hypertensive. More than 140 by more than 90 is considered as the hypertensive. But in the ambulatory blood pressure, look at it, the nighttime blood pressure, a sleep average, more than 120 and more than 170 millimeter of mercury is considered as the hypertensive. And the home blood pressure more than or equal to 135 or 85 or more is considered as the hypertension. So the methods of measures also matters. And this is the importance of the ambulatory blood pressure monitoring in predicting the prognosis. There is a study which is published in 2006. There is a cohort of the 217 patients with the chronic kidney disease, ambulatory blood pressure monitoring and clinic blood pressure was measured, and the follow-up was made on the 3.5 years. Composite endpoint was the end-stage renal disease or death. And it is found that the blood pressure obtained by the ambulatory monitoring are a stronger predictor of the end-stage renal disease and death compared to the blood pressure obtained from the office or the clinic. And the non-dipping has been associated with the greater prevalence of the left ventricular failure and poorer cardiovascular outcome. So there is a statement published in the American Journal of Kidney Diseases that is a stronger association between the blood pressure obtained from the ambulatory blood pressure monitoring with cardiovascular and renal outcome. That is 24-hour ambulatory blood pressure has been considered the preferred metric of blood pressure. Particularly in cases of the chronic kidney disease, ambulatory blood pressure monitoring is necessary because there is increased incidence of the white coat and masked hypertension. Also, there is a more incidence of the nocturnal hypertension, non-dipping status, masked hypertension. So there is a higher risk of progression to the chronic kidney disease and the cardiovascular disease. So they advocated for the ambulatory blood pressure, preference of the ambulatory blood pressure over the office or clinic blood pressure. And these are the different guidelines, or they define the blood pressure in different way. SEC guideline in 2017 and the ESC guidelines on the 2018. There is some discrepancy that in the SEC, the stage 1 is considered as 130 to 139 millimeter mercury systolic, and 80 to 89 is considered as the stage 1 hypertension, and more than that is the stage 2. But look at the ESC guideline. ESC guideline, the high normal, that which one is the, which one is considered as the stage 1 hypertension? In the ESC guideline, it is considered as the high normal blood pressure. And above that, they graded the hypertension into grade 1, grade 2, and grade 3. But this one, also included in the ESC guideline in 2018, they have a good idea that not only the level of the blood pressure is important, this is important, but this is also in view of the presence of the other risk factors which matters regarding the risk of the patient. As for example, you see there is no other risk factor. If the patient has got only the hypertensive, but no other risk factor, then even when the blood pressure is more than when the blood pressure is 180 by more than 110, the patient is on the high risk. But when the stage 3 means established cardiovascular disease, chronic kidney disease grade 4 or 5, and diabetes mellitus of the organ damage. Even when the blood pressure is 130 to 139 and 85 to 89, that is the high normal blood pressure, the patients are at very high risk. So we have to consider the level grading of the blood pressure in one side, and also the staging depending on the presence of the number of the risk factors. So this is a very good practical approach to management of the blood pressure, and it rightly pointed out that the presence of the chronic kidney disease is the stage 2, grade 3 is the stage 2, and grade 4 or 5 is the stage 3, and so they are at the very high risk even when the blood pressure is the high normal. And the prevalence of the hypertension in the as the glomerular filtration rate decreases, it shows that when the more than 90 ml per minute, the hypertension rate is around 20%, is the usual the community level in prevalence of the hypertension. But gradually, as the GFR decreases, the prevalence increases, so much so that when it is stage 4, the prevalence of the hypertension is as high as near about 80%. So prevalence rate of the hypertension in CKD is 60 to 90% depending on depending on the stages of the CKD. And what is the mechanism of the development of the hypertension and the chronic kidney disease? Mechanism is the fluid and salt overload, activation of the renin-angiotensin-aldosterone system, activation of the sympathetic nervous system, and endothelial dysfunctions. These things are depicted schematically this way. Whenever there is a chronic kidney disease, there is a loss of the renal nephrons, and they result in the endothelial dysfunction. There's an endothelial dysfunction, there is an increased renin production, there is a decreased sodium excretion, and also there is the activation of the sympathetic nervous system. All these are activated. So resulting in the increased peripheral constriction, increased sodium absorption, and the increased sodium retention, and the increased arterial stiffness, resulting in the extracellular volume expansion. All this leads to the increased systemic blood pressure. So this is the mechanism how the blood pressure develops due to the chronic kidney disease. And again, the hypertension from the kidney disease, and hypertension is a major risk factor in the progression of the chronic kidney disease the other way. How it occurs? Because the autoregulatory process of maintaining the interglomerular pressure, which is the inherent of the kidney, is lost due to the consistent raised systemic blood pressure, leading to the raised glomerular pressure, nephrosclerosis, and progressive loss of renal function. So this is the way the hypertension causes the chronic kidney disease results in the hypertension. So hypertension is a major risk factor for the development and progression of the albuminuria and any form of the chronic kidney disease, and the effects of the blood pressure lowering on the renal function and albuminuria are dissociated from cardiovascular benefit. And the eGFR, microalbuminuria, and blood electrolytes should be monitored. This is the recommendation from the recent published guideline by the International Society of the Hypertension. They further said the lower eGFR is associated with the resistant hypertension, masked hypertension, and elevated nighttime blood pressure values. And blood pressure should be lowered 140 to, it is more than 140 or 90 millimeter mercury, and treated to a target to less than 130 by 80 millimeter mercury. In the elderly patient, the systolic pressure may be a bit higher, less than 140. And their recommendation is the RAS inhibitors are the first line drugs because they reduce albuminuria in addition to the blood pressure control. And the CCBs and the diuretics may be used along with the RAS inhibitors where necessary. And the ESC guideline, that the statement of the ESC guidelines of the chronic kidney disease with hypertension, they found that the hypertension is the second most important cause of the CKD after diabetes. And hypertension may also be the presenting feature of the asymptomatic primary renal disease. And the diagnosis of the hypertension-induced renal damage is based on the finding of the reduced renal function and or detection of the albuminuria. The important point to note that the blood pressure reduction by the antihypertensive treatment often leads to an acute increase in the serum creatinine by as much as 20 to 30%, especially with the renin-angiotensin system blockers, which has a functional basis and does not usually reflect the manifest renal injury, which we encounter frequently in our clinical practice, that after lowering the blood pressure, the serum creatinine rises. So a lower the albumin creatinine ratio is measured from a spot urine sample, which is now available, and progressive reduction in eGFR and increased albuminuria indicates progressive loss of renal function. And serum creatinine, they also suggest, as the International Society of Hypertension, ESC guideline also suggests to measure the serum creatinine, eGFR, and albumin creatinine ratio in all the patients of with hypertension. And this is the class 1 indication of the measurement of the serum creatine and eGFR, the class 1 indication to measurement of the urine albumin creatinine ratio, and renal ultrasound and Doppler examination should also be considered in patients with the impaired renal function. It is a class 2 indication. These are very difficult to treat hypertension. There is two types: the resistant hypertension, that is those who receive the 3 or more antihypertensive agents, one of which is the diuretic without adequate BP control. Another is the refractory hypertension, receiving 3 or more antihypertension, one of which is a thiazide diuretic and another of which is spironolactone without the adequate control of the blood pressure. And it is resistant and refractory hypertension in chronic kidney disease are common, especially in these stages 4 and 5. These are the general outline of the management of the hypertension by the ESC guidelines. You see everywhere there is a lifestyle advices there. And whenever there is a grade 1 hypertension or even the high normal hypertension, when there is a risk factor such as the cardiovascular disease or the kidney disease or the hypertension mediated organ damage, then we have to start the drug treatment even at the lower level of the hypertension. And they made an algorithm of the hypertension with the chronic kidney disease. The initial therapy is the AC inhibitors or ARBs plus calcium channel blockers, or AC inhibitors or ARBs plus diuretic, particularly loop diuretic in case of the stage 4 or 5. And if necessary, we have to go to the step 2, where all the 3 drugs are combined: AC inhibitors or ARB plus CCB plus diuretics. And the step 3 is the resistant hypertension, where we have to use the spironolactone or other diuretics, alpha blockers or beta blockers. So this is the good algorithm for the practitioners to follow. And mind it, the loop diuretics are used when the eGFR is reduced to less than 30 ml per minute. This is the recommendation. Class 1, the office blood pressure. When there is a more than 140 by 90 millimeter mercury, you have to initiate the antihypertensive treatment, lifestyle modification and drug therapy. Chronic kidney disease with or without diabetes, lower blood pressure to 130 to 139 millimeter mercury systolic blood pressure. It is the class 1. RAS blockers are recommended in the presence of proteinuria or albuminuria. It is also class 1. And RAS blockers in combination with CCBs and diuretics to be the initial therapy, while necessary, it is also the class 1. But mind it, the individualized treatment according to the tolerability and the impact on the renal function and the electrolytes are advocated. They showed that in meta-analysis, the BP lowering significantly reduced the end-stage renal disease in patients with CKD, but only in those with the albuminuria and without any beneficial effect on the CV events. And current evidence suggests that in patients with the chronic kidney disease, BP should be lowered to less than 140 by 90 millimeter mercury and towards the 130 by 80 millimeter mercury. And another point is important, that sodium restriction may be especially effective in aiding blood pressure lowering in patients with the CKD, as there is a retention of sodium and fluid in the pathogenesis, as I showed before, in the pathogenesis of the hypertension of the CKD. And the statement from the SCC guideline, which is published in 2017, they also reported that the hypertension is reported in 67 to 92% of the patients with the CKD with increasing prevalence as kidney function declines. And the mass hypertension, they stated that occur in up to 30% of the patients with the CKD, and the portends high risk of the CKD progression. So CKD is an important risk factor for the cardiovascular disease in the other way also. Coexistence of the hypertension and the chronic kidney disease further increases the risk of adverse cardiovascular and cerebrovascular events, particularly when proteinuria is present. So most patients of the chronic kidney disease die from the cardiovascular complications. This is a very important point to remember. The cardiovascular complications are the main point of death from the chronic kidney disease. Lower target of less than 130 by 80 for all patients with the CKD. But the incremental BP reduction may be appropriate because the careful monitoring of the physical and kidney function assessment is necessary. Their recommendation is Class 1 is the adults with hypertension and CKD should be treated to a BP goal of less than 130 by 80 mmHg. It is similar with the European guideline. And in adults in the hypertension with CKD, they advocate the ACE inhibitors to slow kidney disease progression. It is a class 2A, and the ARB in place of the ACE inhibitors. If in tolerant patients, it is a class 2B. So, an ACE inhibitors or ARB is a preferred drug for treatment of hypertension if albuminuria. And they also mentioned that the serum creatinine may increase up to 30% because of the concurrent reduction in the GFR. Reduction of the GFR that occurred during the intensive BP is largely hemodynamic effects other than the kidney injury. But if the GFR is reduced further, then further investigation are advocated. Their algorithm is that the BP goal is 130 by 80, class 1 indication. We have to start the treatment to reduce the blood pressure to below the 130 by 80. If there is a albuminuria, then ACE inhibitor is class 2 indicated, and if no, the other first-line drugs may be used. And then this is the guideline, which is from the kidney people, the kidney diseases improvement global outcome. They have got their own guideline. They're depending on the albuminuria. If there is a less than 30 milligram albuminuria, then BP target is less than 140 by 90 without any preferred agent. If the 30 to 30 milligram or more than 30, the BP target is less than 130 by 80, and ACE inhibitors ARBs are the preferred agent. The recommendation is irrespective of the presence or absence of the diabetes. No recommendation given by them for the stage 5 or the ESRD, end stage renal disease. So this is a statement from the European group, a group of authors. Their recommendation in the case of the patients of the dialysis, non-pharmacological intervention targeting sodium and volume excess are fundamental for BP reduction in this population. They recommend use of beta blockers followed by the dihydropyridines. CCB should be considered. The first-line use of ACE inhibitors in ARBs in this population is not supported by the randomized trials. The safety profile of the mineral receptor antagonist in the mineralocorticoid receptor antagonist in the dialysis population are being studied, but need further investigation to weigh benefits versus adverse effects. Properly designed epidemiology studies and clinical trials are necessary to further recommendation on these patients. So most in the transplant patient, most studies favor the CCBs to reduce graft loss and maintain higher GFR, and with some evidence suggesting that there may be potential harm from the ACE inhibitors. There is another interesting paper that there may be role of uric acid lowering therapies in the management of hypertension in addition to the prevention of the CKD, but there is no further, many further comments on this paper. They found that the hypertension increased by 13% per 1 milligram per deciliter in increase of the serum uric acid. They have from the 18 prospective cohort studies, and the baseline serum uric acid more than 6.5 milligram per deciliter had a 25 increased risk of hypertension. So, my dear fellow colleagues and the friends, at the end of this presentation, my take-home message is hypertension leads to chronic kidney disease, and chronic kidney disease complicates with development of hypertension. Target office blood pressure is set at less than 130 by 80 millimeter mercury in CKD patient with or without diabetes, according to the major guidelines. Mask hypertension and nocturnal hypertension is reported in a significant number of the patients of the chronic kidney disease. So ambulatory blood pressure monitoring is advocated for managing hypertension in the CKD group of patients. And the dietary salt restriction and appropriate diuretic therapy make up the mainstay of the hypertension treatment. RAS inhibitors are recommended agents in the CKD patient with albuminuria. Fall of blood pressure may be associated with functional rise of the serum creatinine with fall of GFR up to 30%. RAS inhibitors may be combined with CCBs and diuretics if necessary, and bedtime dosing may help in non-dipping cases. Resistant and refractory hypertension are frequently encountered in the chronic kidney disease patients. Thank you very much for the patient hearing. Bangladesh welcomes you to look at the sea beach at Cox's Bazar and the Sundarbans, the home of Royal Bengal tigers. welcome to Bangladesh. Thank you very much for the patient here.
Thank you very much, Professor Abdullah, and very much enjoyed your talk. And I have a question on the clinical practice. Sometimes the CKD is the end stage. For example, let's say serum creatinine level is more than 3. If we decrease the hypertension, blood pressure, the serum creatinine more increase. And you said that it does not always mean the red kidney injury, but do you think we have better keep the blood pressure relatively high level in patients with end-stage renal failure, or should we keep the low blood pressure even though in patients with end-stage renal failure? Do you have any comment on that?
Thank you, Dr. Koz. Very nice question, because I also thought about it. The thing is that there is a lot of studies for the last 2 or 3 decades. There is a lot of studies of how much blood pressure should be reduced or not. It has been found that there is no harm of reducing the blood pressure below 130/80. Rather, it decreases the progression of the renal disease as well as the progression of the other cardiovascular and the cerebrovascular complications. And the rise of the serum creatinine is expected up to 20, some say up to 30% without any kidney injury. Rather, it reflects the functional effects or hemodynamic effects of the lowering of the blood pressure. And the suggestion is that if the creatinine level rises more than 20% or 30%, then we have to investigate whether there is any further kidney damage or not. If no, then we should not be worried about it. We should think that the beneficial effects are more than the concern about the rise of the creatinine. This is my idea. And you see the patient on the 5th stage, that is the end-stage renal disease, this is very controversial still now. And particularly the patient who are on the dialysis. And there is no robust data about the antihypertensive management in the patients on the dialysis, but as I showed, that there is a consensus statement from different groups of people from Europe who suggested to use the beta blockers, calcium channel blockers, rather than the ACE inhibitors to ARB in cases of the patients with the end-stage renal disease.
I have a question, Koji.
Yes, sure. Welcome.
Congratulations, Professor Shafi. In the use of antihypertensive drugs like hydrochlorothiazide, how far is it effective in basing on the GFR level of the patient? Is it if the GFR is very, very low? Or
yeah, as I showed that up to 30 ml per minute per square meter, 1.73 square meter, we can use the thiazide diuretics. But below that, we have to switch over to the loop diuretics. I have already showed in one slide. Regarding the spironolactone, this is a very critical way to use it. In the resistant hypertension, you have to use the spironolactone to lower the blood pressure. But you have to keep in mind about the level of the potassium and particularly the potassium. So even then, this is not contraindicated. Rather, use is with the caution and the follow-up and monitoring.
Thank you.
Is there any comment from Mongol or Dr. Kishi or?
Yeah, I have one question. And Professor, what type of antihypertensive drugs you would advise for secondary hypertensions, let's say with chronic kidney disease?
Chronic kidney disease, it is the RAS inhibitors, ACE inhibitors and ARBs. But I think you are also thinking about the renovascular hypertension.
Yes, renovascular.
There is a rise of the creatinine following the use of the RAS inhibitors. Then we have to check whether we are dealing with the patients of the secondary hypertension with the renal artery stenosis. In those cases, we have to, these are the contraindicated in those cases. So secondary hypertension, we have to find out what are the causes of the secondary hypertension, and the renovascular is one of the important causes. Then we have to avoid to use the RAS inhibitors.
Okay, thank you very much. Do you have any comment from Dr. Kishi or
Thank
no?
you.
Okay.
Questions. How do you think about the SGLT2 inhibitors in respect to the treatment of hypertension and CKD? Because for our cardiologists, several recent clinical trials indicated that the SGLT2 inhibitors has a beneficial effect for the hypertension and CKDs with and without diabetes. So what do you think about the benefits of the SGLT2 inhibitors to the hypertension and the CKDs?
I think SGLT2 inhibitors have got the hypotensive effect, but in the it is not yet recommended by any major bodies or societies, or the not by the approved by the FDA or so, as it is recommended or the approved for the heart failure patients. But for the as an antihypertensive, I think we have to yet wait to see the results of the other trials to see if the SGLT2 inhibitors can be a good choice of antihypertensive. But in my clinical practice, you see off-label use. I sometimes use in diabetic patient particularly, I increase the dose of the empagliflozin from 10 to 25 millimeter mercury when I need a slight decrease of the blood pressure. Then I found it very useful, but it is not yet advocated or recommended yet. But data will show, I think, definitely it will be a positive effect on the lowering of the blood pressure, and the CKD patient may be benefited with the SGLT2 inhibitors, but it is not yet advocated by the approved bodies or societies.
Okay, thank you very much, Professor Bangladesh, and all of the speakers for excellent lecture, and Professor President Jack Down for the chair. And finally, I greatly appreciate Professor Jim Lee Lin Taiwan Heart Foundation to organize this excellent webinar. Professor Lin, do you have any comment in the last?
Oh, it's muted. It's muted.
Please unmute. Professor Lin, you have to be unmuted.
Yes. Oh, okay. Yeah. So you hear me now? Yeah. Okay.
Yes.
Great. Thank you for all you to attend the webinars, and I really have learned a lot from all of you actually. So well, I think I will also welcome all of you to next week. We have a part 2 of the dilemmas of hypertension. You'll be very much interested as well. And I must be closer to Professor Hasekawa, please. Yeah.
Yes, thank you very much, Professor Lin. And I think the time has already past 2 p.m. So it's now time to close. And thank you very much for all. It was a very excellent web seminar. Looking forward to the next week webinar too. Thank you very much for all.
Thank you, everybody. Thank you.
Thank you, everybody.
Thank you, Dr.
See you
Lee.
later. See you later. See you later.